Hello, thanks for watching. This is Ask the Pearl from the Pearl Women's Center in Portland, Oregon, episode 4. I am Nick Fogelson, and this is...
I'm Rick Rosenfield.
And we are going to be talking about current topics in obstetrics and gynecology. We've gotten a lot of viewers and a lot of questions from previous visits, and or previous episodes, rather. And we look forward to this as well. So we're going to talk today about endometriosis. This is something that we see quite commonly in our practice. We get a lot of referrals for endometriosis, both in the local Portland and Oregon area, as well as nationally around the country, because it's an area that we have some expertise in.
That's right, Nick. As a matter of fact, somewhere in the ballpark, about 15%, we think of at least 15% of patients are afflicted with endometriosis. And this is a disease that's very difficult to manage. Sometimes it can be very complicated in the way it presents to our practices as well. The two main areas that we'll focus on as far as when we recognize endometriosis are both in the workup and the treatment of patients with infertility, as well as the workup and the treatment of patients with chronic pelvic pain. Would you agree, Nick?
Yeah, I think so, and that's really the two things that really lead us to make the diagnosis. The most common presentation of endometriosis is a woman who has really difficult menstrual cycles. Sometimes they describe killer cramps, and there's even a sort of a national campaign that they say killer cramps are not normal. Because a lot of women have severe menstrual cycles and very painful menstrual cycles, and they've kind of been told that there's nothing wrong with them and that it's just tough to be a woman and it's very painful. The reality is that a woman without endometriosis typically has cramps that last for a few days, and they can take some ibuprofen or Tylenol or nothing and everything is fine. Whereas a woman with endometriosis can have really severe pain with their menstrual cycle that can last for many days and often precedes their cycle as well, where the days leading up to the cycle can be incredibly painful. And it can be really, really severe to the point where sometimes women are at home for several days, they're not able to go to work. And then they also have pain when they have sex often, and usually it's with any kind of sex with deep penetration, they can have terrible pain and it can really interfere with the relationship with their partner.
And interjecting even further than that is there's also another category of patients that sometimes are completely overlooked, and that's our teenage population. Right. Sometimes these are young women, young girls that are in school that their first menstrual cycle is unbearable, and it continues to get worse and worse as they get a bit older. And oftentimes these things are discounted by their parents and by their teachers and by their friends, yet these are patients of ours that are severely debilitated by this pain. This is stuff that can impact people. If you think about a menstrual cycle and the menstrual bleeding, sometimes lasting a week or even longer, this is 1/4 of some of our patients' lives where they're afflicted with severe pelvic pain. So it's a very significant issue. And speaking of pelvic pain and the statistics, it's pretty amazing that about 80% of patients that go into a patient, but about 80% of patients
I usually leave it in, actually.
You like that? About 80% of patients that go into a physician's office for a workup of pelvic pain are actually misdiagnosed, and I think a lot of the reason for that is that the physicians aren't really giving them enough time in the office to really go through their medical and their physical history.
Right. And honestly, Dr. Rosenfield and I deal with endometriosis a lot, and when we see a patient that fits the diagnosis, we'll go fairly quickly to making a definitive diagnosis, and that's typically via a surgery called laparoscopy, whereas a lot of people will kind of blow it off for a long period of time or use sort of ineffective methods to treat it before they take that step. So that's the difficult part.
Let's go back to kind of the basics here.
Yeah.
So we're talking about a condition called endometriosis, and the definition of that would be that the endometrium, which is the lining of the uterus, this is the part of the uterus that sheds every month in a normal menstrual cycle, the idea being in a female body, of course, to get pregnant. And if someone does not get pregnant in any given cycle, the menstrual lining sheds. Now, the cells that make up that lining are called the endometrium. And if those cells are located in other parts of the body, that condition is called endometriosis. Exactly.
Right, and osis just means that something is present. So endometrium is present, and it's outside the uterus. And endometriosis is endometrium outside of the uterus. The typical locations is on the peritoneum of the inside of the pelvis. And the peritoneum is like the skin on the inside of the pelvis. All of our organs have this sort of skin around them. And some of that skin is very tightly bound to the organs, such as on the bowel itself, where that skin doesn't come off. And then at some of the areas, the skin will move, almost like my skin moves on the back of my hand. You'll get kind of a layer in there that can move around, and that can become infected or sort of infiltrated with endometriosis as well.
And if you've seen pictures of this, actually that skin, that lining, the peritoneum actually almost looks like cling wrap, saran wrap, that type of thing. It's a very translucent material, very glistening, and should have kind of a slippery texture to it where the bowels and other organs can gently move back and forth and allows for your digestion and things to work in a normal function. When endometriosis is present, there are very specific changes that we'll recognize both surgically and with a patient's presenting symptoms. And some of those things can be inflammation, or it can almost have an appearance that somebody has poured super glue in your pelvis and things are stuck together, which can explain why there's such a wide range of symptoms in our patients that we see at the clinic.
Right, and we'll see even this real translucent skin will look kind of opaque, where when it's early disease, it just doesn't look glistening anymore. It looks kind of this sort of dull appearance. And honestly, when you looked at endometriosis for a long time, you start to recognize that. So it's interesting. How did it get there? Why is there glands outside of the uterus? Because there really shouldn't be. There's an old theory that was created by a gentleman named Sampson, and it was in the 1920s, and that the blood that's in the uterus during the menstrual cycle actually retrograde menstruating, which means coming out of the uterus, out of the fallopian tubes, and ending up in the pelvis. And then some of those cells will end up kind of sticking to the pelvis and creating endometriosis. It turns out that this is probably not true. This was the ongoing theory for a long, long time, but we know now that it's almost certainly not true. One of the reasons we know it's not true is that we can find endometriosis in people long before they menstruate.
And we also recognize that a lot of patients that do have retrograde menstruation, where we might be taking a patient to the operating room during their menstrual cycle, and we see that there's blood going backwards into the pelvis, have no evidence of this disease at all.
Right. It just doesn't seem to fit. And anytime you go back and you find a theory that's 100 years old, a lot of times it's not going to be right. Like, we didn't even understand DNA, we didn't understand biochemistry. So little was understood when this theory came to be that it'd be hard to believe that it ever would have been completely accurate. So the newer theory, which I think is far closer to correct, if not completely correct, is that during embryogenesis, during the time that a woman goes from being a one-celled embryo into the fully formed baby, and then on to being an adult, during that embryogenesis, the cells that should have only been in the endometrium are actually being laid down outside of the pelvis in kind of a dormant state, like sleeper cells of little terrorists in there. And when they when the woman starts menstruating and the signals from the ovaries start talking to those endometrial cells, okay, get ready for a pregnancy to come in, the cells that are outside the uterus are responding to the same signals and creating swelling and inflammation.
They become endometrial or endometriosis. How's that?
Yeah. Oh my gosh. So, endometriosis. So, basically all these cells have been laid down out there. And retrograde menstruation just doesn't really fit, because we can find endometrial cells on the diaphragms up here, way up in the top of the abdomen. In really severe cases, it can even grow through the diaphragm and affect the lungs. And furthermore, endometriosis can be anywhere. In fact, every single tissue in the body there has been reported endometriosis in at some point or another, except for the spleen for some reason, and that's what was reported by Cameron Najat. I've never been in the spleen. I'm not sure if that was right or not, but it is truly everywhere. I've removed endometriosis from lung tissue. I've removed it from diaphragms. I've taken it off liver. I've taken it off bowel, bladder, ureters. It can be everywhere.
And the important thing that what Dr. Fogelson's mentioning here is when he says that he's removing it. And I think that's going to get into probably the core of our take-home message from this presentation, which is, first of all, it's impossible to diagnose endometriosis without doing surgery unless you have a large cystic lesion on your ovary, which would show up during imaging. The majority of endometriosis, unfortunately, is not visible with diagnostic testing, which would include labs and imaging. So the unfortunate reality is most of the time you're going to need to have a laparoscopic surgery with a little incision inside the belly button where we can put a camera into the pelvis to look around for this disease. Once we recognize the disease, the question is, what are we going to do with it? And what Dr. Fogelson just mentioned was removing disease, and I'm going to let him touch a little bit on the difference here between two major camps, I would say, in treatment. One of them is talking about fulguration, and the other one is about excision. Nick, do you want to talk about the difference?
Right. So the fulguration is a type of a generalized idea called ablation, which means that you basically burn the disease that's on that skin of the peritoneum in some way. So when you ablate disease in the peritoneum, people do feel better for a while, but the problem is that they almost always get worse again, because endometriosis is a disease that is invasive into the tissues it attaches to. And any kind of ablation technique is really superficial. It's just touching the top of it. Just like there's a big iceberg under the water. If here's the water line and here's my iceberg, you're just kind of cutting the top off, but you still have all this disease underneath. So any kind of ablation technique is kind of doomed to failure in the vast majority of the cases, unless the endometriosis is really superficial. Then you may be able to ablate it away. But if it's deep at all, then you really have to do something called resection. So resection is just a medical word for cutting, where you actually cut the disease out. You physically dig up underneath the peritoneum that has endometriosis on it, and you remove it permanently. And because the theory now is that the disease has been there since birth, it's not that it gets deposited there later in life and that it's going to keep coming back, but rather it's been there forever. If you remove it, you really should be permanently removing it. It shouldn't come back. And that's the important part. The problem is that resection of endometriosis is technically a very challenging thing to do, and a limited number of surgeons actually have the surgical ability to do it for lack of combination of things. One is just sort of a dedication to really deciding to become good at it. It takes a long time, a lot of understanding of anatomy, sometimes specialized training. And most general OBGYNs spend a lot of time delivering babies and doing a variety of things, and they just don't get very good at resection of endometriosis.
The other part of that is that the management of patients that have chronic pelvic pain and endometriosis, first of all, there's a significant workup that needs to happen. A lot of patients that see us at our office do not have endometriosis. They may have another condition that's creating their pelvic pain, and that requires a longer visit in the office. Oftentimes, physicians that are out there that are seeing a lot of pregnant patients really only have about 15 minutes, maybe maximum, for a face-to-face interaction. And we spend at least twice that amount of time just going through records and having the opportunity just to talk with the patient, oftentimes before they even come in and see us, to try to figure out what's going on. Once we get an idea that endometriosis is present, we typically recommend the surgical route, because the medical treatments that are available really are not treating the disease process. They're only treating the symptoms, which means that they're going to give you a short-term result only, and we're looking for a more long-term answer for our patients, especially for folks that are interested in achieving a pregnancy. And the thought of why endometriosis can be a problem with achieving a pregnancy is not only the physical obstruction that endometriosis can create in the fallopian tubes, but it also can create a very unhappy environment in the pelvis with inflammation. The thought is that the inflammatory reaction that's occurring in the pelvis can actually be devastating to the early viability, the early survival of an embryo once the sperm and the egg meet. So it's a very significant condition that we take it very seriously here at the Pearl.
Yeah, and even before that, the egg itself is very fragile, and in fact, it may be the egg that gets killed by the endometriosis. A human egg is a tremendously fragile structure. I used to work with an embryologist that would say that you could practically step on a gorilla egg and it would be fine, but a human egg, you can breathe on it wrong and it will die. And that seems to be the truth. So the pelvis, in a person that has endometriosis, every single inflammatory marker that we know of is out of whack when people have endometriosis. One is called IL-6, one are called natural killer cells. We see a lot more activity of macrophages, which are particularly part of our immune system. Basically, it's like the pelvis has become a war zone, and the immune system is trying to kill off this inflammatory stimulus, and it's gone in there it's like carpet bombing the pelvis to try to get rid of the endometriosis. The problem is that there's a tremendous amount of collateral damage. Eventually, I think the endometriosis is killed off, and I've seen people that have horrible scarring in their pelvis, but when you go and remove it, the pathologist says there's no endometriosis. And what I know is that they had endometriosis in there 10 years or 15 years before, but really now what they have is a burned out hulk of a pelvis, and because of the war that's been going on there for 20 years. And you know that that's the only condition that could have caused the pelvis to look like that, even though it's kind of all burned out at that point.
And an important thing to think about when you try to understand this disease process, the endometrial cells that we're talking about, they react to hormones. And so the endometrium is stimulated by estrogen, just like a menstrual cycle would be. It also can be suppressed by hormones like progesterone. So these are the menstrual hormones that we would be measuring in a reproductive age woman. If you think about the endometrial cells being alive and being implanted in different areas of the body, certainly if you cause them to grow by giving them estrogen, that can create pain. And that's what we typically see, is this escalation of pain. Patients come in and they talk about right after their period they feel okay, and then as they get to mid-cycle things are maybe not great, and then definitely toward the menses itself they get this crescendo, this escalation in pain that becomes completely debilitating by the time they go on to their period itself. And that's kind of a classic description of endometriosis, definitely the theories of how it forms, and absolutely our opinion, which we feel is an expert opinion on how to treat the disease, which is removal. I will mention that Dr. Fogelson has several videos that are available online. We will continue to post more surgical videos of how we approach endometriosis. We do recognize that a lot of patients that are out there are seeking good surgeons and good doctors that may not be in their local area. We're always happy to talk to individual patients about the possibility of visiting us in Portland, and we'd be more than happy to take care of you and your friends that are out there that might be interested in this particular topic.
Absolutely. It's we get people from all over the country, and particularly in the Pacific Northwest. There aren't that many people in the country that really have taken enough of an interest in this to get particularly good at it, and we're really happy to be a resource to our community to really take care of patients with endometriosis.
And I'll tell you, one of the best things we ever get, though, is when a patient comes up to us after one of these cases that we've done, and either A, they're pain-free, or B, they've achieved a pregnancy. And those are really rewarding situations for us to participate in. Sorry to interrupt, Nick.
No, not at all. So I completely agree. I've been dealing with endometriosis, most of my career, and kind of made a niche specialty of it. And Dr. Rosenfield's really active in it as well. And we're doing really cutting edge stuff here at the Pearl Women's Center. It's great to operate with us together, working together to really do thorough resection of endometriosis in the patients that we have. We're able to do it in our own surgery center in the vast majority of the cases, and in the real complex cases, we go to the hospital at times as well. And we're a great place to come if you have that kind of problem.
Sure. Well, we'll probably sign off for now. I'm guessing that we'll get a few questions. We would love to follow up. Endometriosis is a very complex topic. There's books written about it. So for us to try to get everything in a 10 or 15 minute discussion is not quite enough. But we welcome your questions. We're happy to answer them. We also welcome your input through social media and email.
Yep. Thanks very much for listening, and stay tuned for more Ask the Pearl. Make sure you like us on Facebook. We're at Pearl Women's Center if you're not already seeing it on our Facebook page. And we'll see you next time.
Absolutely.